And so we have created the HOPE framework, Healthy Outcomes from Positive Experiences framework. And it's not rocket science, right? If you work with kids or if you have kids, what I'm about to say is going to feel fairly obvious to you. But we know that kids need safe relationships. Kids need access to safe environments. Kids need opportunities to be part of something bigger than themselves. And they need opportunities for emotional growth.
Hello, everyone, and welcome to Partnership Perspectives. This is a child welfare training and educational podcast for those already working in or with an interest in working in child welfare in Rhode Island. My name is Stan Brazier, and I'm the project director for the Learning Partnership between the Rhode Island Department of Children, Youth, and Families, or DCYF, and Rhode Island College. Our desire with this podcast is to bring information from experts on a variety of topics, all at no cost to hardworking professionals and others. Today, I'm very excited to speak with our guests about positive childhood experiences, or PCEs, and the HOPE framework, which stands for Healthy Outcomes from Positive Experiences. Much has been written about ACEs, or adverse childhood experiences, and if you've come to a lot of the ongoing trainings that we've been partnering with the department on, you've probably heard about this. But what about positive childhood experiences? Many of us are probably familiar with the ACEs study that was conducted back in the 90s, and its importance for understanding of how these adverse experiences can correlate with poor outcomes in adulthood, but how many of us are really familiar with the research that's going on for PCEs? Our guest today is going to help inform us about some of this research and, most importantly, what it means for you and your work with children, youth, and families. Please note that the views expressed by both the host and guests of this podcast are their own and do not necessarily reflect those of their organization, the college, or DCYF. So without further ado, our guest today is Amanda Wynn, the Director of Training and Technical Assistance at the HOPE National Resource Center. Amanda has spent her professional career working at the intersection of parenting, gender, and poverty. Amanda directed a National Resource Center out of UC Berkeley School of Social Welfare, providing training and technical assistance to providers around the country, supporting families affected by substance use and/or HIV. She's also worked extensively supporting LGBTQ+ families at the school district, medical, and community levels. Amanda, welcome, and it's great to see you.
Hi, thank you so much for having me. I'm excited to be here.
Of course. Thank you for taking the time to meet with us today. So I was mentioning in the intro, the ACEs study. This was, happened in Kaiser Permanente, and I forget who the specific doctors were, right? But we don't say everyone, but lots of us know about the ACEs study, and it's become so well known in social work and child welfare. Can you tell us what the impetus was for the shift to studying PCEs, or positive childhood experiences, as opposed to ACEs?
Yeah, absolutely. So like you said, ACEs caught on pretty quickly in the early 2000s and really launched trauma-informed care as we know it now, right? And so there was a lot of interest in learning more about ACEs. And so there is a research study that happens in every state across America called the Behavioral Risk Factor Surveillance Survey Study, or BRFIS for short, which I try to not make it through a day without saying BRFIS. So I encourage you all, it's a fun one. But this BRFIS study is a phone screen. So researchers call adults and ask them lots of questions about their demographics, their current health and well-being, and then often about their ACEs, or hard things that happened in childhood. And they were able to really get a sense of correlations between those adverse childhood experiences and adult health and well-being. Well, back in 2015 in Wisconsin, those researchers decided that they also wanted to ask some questions on their BRFIS study about good things that happened in childhood. They were curious to see if positive childhood experiences had any impact on adult health and well-being. So they added some questions to their BRFIS study. And what they found was that, yes, actually, it seemed to be that the more positive childhood experiences people could recall, the better their adult mental health was. And so in this first study in Wisconsin, those correlations really were just pretty tightly contained to adult mental health, right?
In terms of like the impetus, was it really just this group in Wisconsin? Or was it sort of their out of their own curiosity and their own volition? They said, well, hey, wait a second. Why don't we ask about positive childhood experiences, even though we've been asking about adverse childhood experiences? Or was there any other kind of like rationale behind the asking about PCEs in addition to ACEs?
It's a great question. I'm not sure what initially caught their interest. I know the World Health Organization was doing a study on positive childhood experiences at the time that I think that one of the folks in Wisconsin was involved in. And so that's where the original questions came from, was that World Health Organization study. We see this correlation between mental health and positive childhood experiences. And then more states started adding these questions. And as more states added them, the sample size got bigger, and we were able to see that not only did positive childhood experiences promote adult mental health, but also adult physical health. So adults were reporting better cardiovascular health, lower rates of substance use across the lifespan, better well-being outcomes, right? They were more likely to be employed full-time, higher household incomes. And so these results started catching the attention of Dr. Robert Sege, who is our fearless leader at HOPE, Dr. Charlene Harper Brown, who works for the Center for the Study of Social Policy and is a big name in the strengthening families field, Dr. Jeff Linkenbach, who runs the Montana Institute and the Science of the Positive. People were starting to take notice of this notion that good things that happen in childhood are also impacting health and well-being. And so it was these individual Burfus studies that started popping up across the country that piqued our attention and indicated that there might be something there to study.
That's pretty interesting. So who's typically included, or is it like randomized who's included in the surveys? And I know there's been a lot of expansion of the research and to make it more inclusive. So can you speak to that a little bit?
Yeah, so it's gotten better. It used to just kind of be a random sample. And clearly there's a sampling bias, right? Because it's a phone screen, which means you have to have a phone and you have to answer your phone.
You have to actually want to pick up your phone when that which a lot of people don't these days. Yeah.
Right. Yeah, absolutely. And so, the types of people who are willing to pick up a phone call from a number they don't know, or a number that says, research underneath it, are a certain type of people, certainly. But the sampling method has over time tried to get a more representative sample of the state that it is researching. So they are trying to balance for the demographics of the state now in their sampling pool.
How many states are using the PCEs included in the Burfus screen?
Also a great question. So they don't need to report that to us.
Okay.
There are lots of states out there. We hear anecdotally when we give trainings like, oh, well, my state added those questions, and that was not a state that was on our radar of data to analyze. So I don't actually have a solid number for you there.
Okay. But there's been more and more over the past, like, say, 5 to 7 years or so.
Yeah, so Wisconsin added it in 2015, and I would say 2019, 2020, 2021, it really took off. And every year we hear that more states are adding questions to try to see how their state lands on this issue.
Right. So besides the maybe a little bit sort of obvious that positive experiences would correlate with positive adult, mental and physical health and well-being, what have you all been doing at the Hope National Resource Center with this research in terms of how does it inform your work?
Yeah, great question. So like I mentioned, when these studies started coming out showing this correlation, a team of really smart people came together that I had mentioned previously, and some others. Christy Bethel was part of that too. And they did a comprehensive look at the field. They were looking at anybody who was talking about good things that happened in childhood and long-term health outcomes. So they looked at things like strengthening families, like the 40 developmental assets, like the benevolent childhood experiences, really any kind of evidence-based or evidence-informed or research studies that were out there on good things that happened in childhood and long-term health outcomes. And what they found was that when they, kind of scanned the field, those types of experiences that had the biggest bang for their buck, so to speak, on health and well-being tended to cluster within 4 areas. And so we have created the HOPE framework, Healthy Outcomes from Positive Experiences framework, around these 4 key areas. And we call them the 4 building blocks of hope. And it's not rocket science, right? If you work with kids or if you have kids, what I'm about to say is going to feel fairly obvious to you. But we know that kids need safe relationships with their caregivers, with other adults, and with their peers, where they feel like they matter, they feel seen and heard. Kids need access to safe environments where they are both physically and emotionally safe and have access to their basic needs. Kids need opportunities to be part of something bigger than themselves, those opportunities for engagement where they feel like they matter and they belong. And they need opportunities for emotional growth, which can happen through unstructured playtime where they're kind of figuring out, what is fair and unfair and how to navigate conflict. It also happens through adults who can model, appropriate reactions to big feelings or help kids name feelings in their bodies. But those are the 4 building blocks, the 4 key types of experiences that we know all kids need to thrive. And then especially kids who have experienced trauma and who might be on track to have some of those long-term health outcomes that we know can be associated with trauma. If we can get more access to these key types of positive childhood experiences into the hands and lives of those children, we can actually change their health trajectory. And we can help them see those same positive health outcomes that are, typically associated with positive childhood experiences. So my job is to work with anybody who works with kids, which could be child welfare. It could be early childhood folks, K through 12 educators, juvenile justice, healthcare providers, little league coaches, literally anybody who works with kids, to think about how we can be creating systems that prioritize access to those 4 types of key positive childhood experiences.
So now that we have this framework and you guys are doing this great work and there's this shift towards positive experiences, are you seeing improvements in systems? Are we seeing improvements in outcomes for kids and families? And if we're not, then what are some of the barriers and what are some of the holdups?
Yeah, so we are starting to see improvements in systems, but as anybody who is listening to this podcast knows, I'm sure, changing a system takes time, right? And so we have found the most luck when we drill down. So we tend to, when we're working with organizations, we might not work with the entire organization. We might work with a department within that organization or a team within a department within the organization that's really excited about rethinking how they do what they do, right? And so that is where we see the magic happen. When you have a team within a system who can pilot changing an intake form so that you're more curious about how kids and families access positive childhood experiences, or thinking about how they do case planning with kids in out-of-home placement to make sure that they still have access to the positive childhood experiences they had when they were home, and their caseworkers and the families that they're living with are also making sure that they have new access to positive childhood experiences. When you see these things start to happen within a team and you start to hear anecdotally that families are reporting, quicker connection to referrals when referrals are made, that they are more engaged in their care, that the providers are actually experiencing lower rates of burnout and higher job satisfaction when the relationships between the families and the professionals are getting better, are improving over time. Then other teams and other departments within that organization is like, hey, what are you doing there? We've noticed things are different. We've noticed your team is different. What is that? And so we can use these like small pilots within a system to get the rest of the system excited. But it's exciting to see the sparks start to happen, right? When you have a small group that tries it and it works.
So there's a snowball effect that's been happening.
For sure.
That's what it sounds like. Okay. So I think also I was going to ask you about type 1 versus type 2 thinking. And that's part of the introduction training that you all have for Intro to Hope 101, because we were just talking about systemic barriers and how difficult that can be for whole systems to change. But it's also really difficult for us as individuals to change our thinking. So can you talk a little bit about type 1 versus type 2 thinking, and maybe what, especially anyone really, but like maybe in particular, like that frontline child welfare staff, the investigator, the social caseworker that's going out to really shift their way of thinking and their mode of thinking from maybe a little less negative and more strengths-based and positive.
Yeah, absolutely. So the reality is that we are all informed by our surroundings, right? The family we grew up in, the schools we went to, the training we've received on the job, all of these things impact how we respond to any situation. And when you're working in child welfare, when you're working on the front lines, when you're going into people's homes, we have been trained to see risks, to see red flags, to see dangers to kids, because it's our job to keep kids safe. And that's really important training that we received, right? We need to be able to walk into a home and very quickly see if there is a danger to ourselves as the frontline workers or to the children in the home. The challenge is that oftentimes that type 1 thinking, which is kind of your gut response to a situation, it's what kicks in when you walk into a house, scan the room, and notice before anything else, oh, there's a lit cigarette on the end table, and those outlets aren't covered, and there's a toddler, and there are cleaning supplies just sitting out, and it looks like maybe the dog pooped in the corner, right? You're scanning the environment to see all of the things without even having to think about it. The problem with that is that tends to be the energy you then lead with in that initial contact with the family in front of you. And I want to be really clear that we are not at Hope telling you to stop screening for risk and for red flags and for potential dangers in the home, that's still a really, really, really important thing that we need to do to keep kids safe. But what we're trying to get folks to think about is what would happen in their relationship with the families that they're working with if they slowed down that gut response and intentionally tried to find things that were going well in that room, in that encounter. Because again, that gut response is going to be to see what is going poorly. But what happens when you slow it down and you can recognize, yes, this room might be chaotic, but the family's all together here. They all want to be in the same room together. They are all clothed and there's food in the house. When we slow it down, we're able to see the person in front of us as a holistic being and not just kind of a sum of their problems or their deficits. And by leading with what is going well for the family, you open the door to creating a relationship that's grounded in trust, in the other person, again, feeling seen for who they are. So that when you do have to have those hard conversations about all of the bells and whistles that went off in your brain when you first walked in, you can do that from a place of relationship and trust.
Those negative things can be so glaring, right? And could maybe in a way overshadow some of the positive things. So what's your advice to those individuals that have to go out and do those home visits or those investigations? And is it just a matter of practice and kind of rewiring the brain, or is it, just taking a moment before you walk into the home to think, like remind yourself, or what's kind of your best sort of advice for strategies around doing some of this shifting of the mindset work?
It's both and, right? It's practice and it's visual cues as a reminder. I do this work day in and day out. I train people multiple times a week about using a strengths-based lens. And still, I can go out to dinner at a new restaurant. And when we're in the car debriefing on the way home how dinner was, my gut response might still be to talk about how slow the service was, or that, the food seemed a little saltier than I was anticipating. And so I think we can start practicing using this strengths-based lens at home where it's safer, right? Where it's safer to make mistakes, where it's a little bit easier because it feels like less is on the line. And I, just for accountability, would encourage you to let the people in your life know that this is something that you want to work on in yourself, that you want to practice leading with strengths, and have them help hold you accountable. I have shared with my kids that this is something that I'm working on. And so that story about going out to dinner, from the back seat, my 10-year-old daughter was like, well, what did you like about it? What was great about the restaurant? And just, again, the more we practice, our brain is constantly rewiring, right? And the more we train it to think a certain way, the easier it is. Those grooves just get deeper and it starts to become more of a gut reaction. So yes, practice at home. In other areas of your life, I've also met folks who just write little reminders and put a little sticky note on their dashboard to take a deep breath and start with their strengths as they walk into a home visit or to a family's house. So I think it's however you learn best, use all the strategies.
Right, great. So, and you also mentioned the screening tools. How can maybe some of the policymakers or some of the administrators think about like reconfiguring or just looking at some of the screening tools that they use it through a different lens?
Yeah. So listen, we're very aware that some screenings and assessments can be changed by the powers that be, and some can't. There are many that can't because you're using an evidence-based model, and for fidelity to the model, you can't change the tool, or a funder requires a specific tool, or you're part of a huge bureaucracy, and to be able to change this one specific thing would take 18 months, right? So a few different things to consider. If you do have power over the screenings that you're using, thinking about if you're asking questions about those 4 building blocks, about how families access relationships, environments, opportunities for engagement, and opportunities for emotional growth. Is there any information gathering happening on your screen or your assessment about those things? And if you were to receive the screening or assessment, how would it feel? Oftentimes, the screenings and assessments that we use can leave the person on the other end feeling worse at the end of it than before it started. So putting yourself in the shoes of somebody who's going to be answering these questions, recognizing that oftentimes the answers to the questions are yes, that it's a positive screen. So how do you ask those questions in a way that helps people feel supported and seen? And like they're not a failure. And we have a whole training that we do around how to prepare folks for screenings and assessments, how to conduct them, and how to close it out using this, what we call hopeful lens, right? So that even if you can't change the form and the questions itself, you can still create an experience where you're able to gather the information you need in a way that isn't further traumatizing to the person on the other end.
Right. Awesome. So, as you were talking, I was kind of thinking back to what you were just answering in terms of like trying to rewire your brain. Is there a way, even at the individual level or even at the systems administrative programmatic level, for ourselves and those program systems to evaluate ourselves after the fact? Because we're not going to get it right every time, and then we're going to make mistakes, and we're going to maybe, like you said, the gut reaction might be to go to that negative thing first. how would one, either at the individual level or at that like more systems programmatic level, evaluate themselves to make sure that they're using the hope framework or just a more strengths based lens?
So a few things come to mind immediately. First of all, we like to encourage organizations across the board at every level to have a community advisory board, right? To engage folks with lived experience in whatever the field is that you're working, who can help you look at your policies, look at your forms, who can even, do some role playing with you and give you feedback on how things are going. Because so often the policies, the forms, the practices are not created by individuals who have lived experience. And so they just land differently. So I think from a quality improvement lens, certainly having folks who are going to be recipients of whatever the policies, forms, and practices are giving you feedback is a beautiful thing. So whether that is a formal advisory council or focus groups or a survey, finding ways to make sure you understand how what you are doing is landing with the folks that you are doing it with in a way that values their time and compensates them. The other piece of it is, we have kind of a formal organizational certification process that folks can walk through that has you look at all of the things we just talked about and areas around creating an internal culture of hope, right? I've heard time and time again that we can train frontline workers all we want, but if they go back to work and their supervisor doesn't prioritize positive childhood experiences or using a strengths-based lens, then that's going to burn out pretty quickly. So we have different ways in which you can help create that internal culture too, ways that you can structure staff meetings or supervision, ways that you can incorporate this framework into your strategic plan and key performance indicators if you have them, so that you're really creating this culture that values strengths-based lens and promoting that equitable access to positive childhood experiences.
I think a lot of times we have, especially in social work and child welfare, we have the new thing or the innovative thing that comes along, and people seem really excited about it, and then they buy in maybe halfway, and then it kind of falls flat. So how do we really buy into something like this and really invest in it in the long term, to make sure that there is a sustainable change? Because I think a lot of times too, people get overwhelmed when that new thing comes along and they say, "Okay, we all have to do this now," and it just couldn't maybe becomes a little bit overwhelming, and they start to. Um, Fall in certain areas and the whole thing doesn't get through, and if it's not all the way, then it loses some of its quality, if that makes sense. So how do we buy into this and really make it like a sustainable piece for everyone?
Yeah, I think we always like to cast a wide net first and to do just kind of a big group training on the framework on what hope is. Because generally speaking, people understand the importance of ACEs, right? And trauma informed care is fairly well defined, but I think it leaves a lot of people feeling like, okay, so now what? We know that ACEs, we know that trauma and adversity can have all of these long lasting impacts. And oftentimes when we meet families, that trauma and adversity has already happened. We are powerless to change it. And so it can leave, especially frontline workers, feeling a little defeated. They're using their trauma informed lens, but it's still heavy to know that the majority of your caseload has a high ACE score. And so what we see when we cast this wide net and do, a broad training on hope is relief from frontline workers that there is something that they can do even after the ACEs have happened to promote health and well-being. And that, again, it's not rocket science. Anybody can do it, right? Whether you have an advanced degree or are a child, we can all be or promote these types of positive childhood experiences. So you see initial excitement from frontline workers and this feeling of hopefulness reinvigorated in the work. And that can take you far. And then we really encourage organizations to train up members of their team to be what we call hope champions, which are people who are trained to deliver implementation support around the HOPE framework. And so you really build out your internal capacity to do the work. And then if you choose to go through organizational certification, we have created a process that really helps you kind of systematically implement in a way that is sustainable down the line, right? We help think through how you're going to onboard staff to these ideas. Again, like what that framework is for supervision and for team meetings. And so I think the excitement around this is the now what, can carry any of the anxieties around something new to do, right? And we like to think about HOPE as not something new, because you could probably all stop and think about the work that you do on a day-to-day basis and find ways that you're increasing access to those 4 building blocks, right? What HOPE is an umbrella to talk so that we're all using the same language to talk about the work that we're doing. And that research base that validates these things that we all kind of want to do, because intuitively in that type 1 space, it feels like these are the things we want to be doing. We want to be building relationship. We want to be helping kids connect to opportunities for mattering. And now we have research that says it works.
Yeah, it's one of the things that I like the most about it is that it's very literal in its purpose, right? It's about giving more hope when I really like the fact that there's research out there too, even though, again, like it's not a surprise, shouldn't really come as a surprise to anyone that positive childhood experiences can help mitigate the effect of ACEs. But it's really good to have some of the research and data to back that up. Because I think that's always another thing that we're looking for in our work too, is just like, okay, well, show me the proof. Like, we know that this is probably true, but we really want the science and the data to back this up. And like I said, very literal in that ACEs and trauma-informed care, that can be very overwhelming. And it's sort of like tough. It can lead to a lot of, probably a lot of compassion fatigue and burnout and all that stuff. But it's good to know that there is, as cliched as it might sound, right, there is hope at the end of the day. I really like that about what you all do and the framework that you guys have brought with using this research and into the foray. So
yeah, I think we kind of like to think of HOPE as part of that trauma-informed care continuum, right? Where the ACEs, the trauma, the adversity has happened in the past, sometimes like immediately before walking through your door, but it's happened in the past, and that is resulting in distress for that individual right now in the present. And that distress really requires that trauma-informed approach so that you can help create safety for that person right then and there. And that by using the HOPE framework and connecting that person to culturally relevant ways to access those 4 building blocks, you're helping build a future of resilience and healing. And so it ties in really nicely to organizations that have already committed a lot of resources to learning about ACEs and to becoming trauma informed, because it's a very, in our minds, a very natural progression of that continuum.
I think also too, trauma it's like Thanos from the Marvel movies, right? It's inevitable. I was just in a training earlier this week, who's experienced trauma? Every single person raised their hand, because it could be any car accident, you lost a loved one, or to the far worse things of physical abuse, sexual abuse, etc. But I think it's important to also, why are we not thinking about positive experiences also being for everyone and inevitable for everyone, that we really need to make sure that every child, every person in general, right, like has access to these building blocks and these positive experiences, because we know that traumatic experiences and adverse life experiences are pretty much bound to happen at some point. It's really hard to go through life without any adversity or any trauma. So let's make it a point to make sure that we're giving people the opportunity to have positive experiences too, right?
Yeah. So Dr. Sege likes to say that PCEs, positive childhood experiences, are the food, not the medicine, that we all need positive childhood experiences, right? And some of the more recent literature is showing that the absence of PCEs can actually be more damaging than the presence of trauma. So that there's this notion that, oh, we really only need to focus on PCEs for kids who've experienced trauma. Well, like you said, by a certain age, most people have experienced some kind of trauma. But what's more important is that everybody, regardless of the negative things happening in their lives, need these positive childhood experiences to thrive. I should actually say positive experiences, not childhood experiences, because what we've seen is that it's never too late, right?
Right.
And that being able to connect adults to those same building blocks can change their health trajectory, even once they've hit adulthood.
Right. I think that's so powerful too, because I think that, when in terms of brain development and things like that, we're looking at children and their brain development being a lot more, there's, I think, a lot more ability to mold that brain development. And then sort of it gets harder when you're into adulthood, but it's good to know that there's still the opportunity. It's just as important, if not maybe even more important, right, for adults to have those positive experiences as well, especially if they've experienced a lot of trauma. So
yeah, definitely.
Yeah. Amanda, anything else you want to add about hope or positive experiences?
I would be remiss if I didn't take a moment to just shout out that those building blocks, the relationships, environment, engagement, and emotional growth are just really big buckets, and that they're only meaningful when the person in front of you gets to tell you how to fill those buckets, right? So hope gives you the key types of positive childhood experiences, but it's not prescriptive. And recognizing that every child or family you work with is going to have different ways they want to engage with each of those building blocks. And to be really careful not to use it as kind of a one-size-fits-all model.
Right. Everyone's unique. Everyone's different. We have to remember that. So sometimes I do think we also get bogged down in, well, this person needs this and that, and because they're presenting with this, and this, and it's this, here's your prescription, here's your positive childhood experiences script, go out and do this, right? But everyone is different. So, Amanda, thank you so much. I appreciate you.
Yeah, thanks for having me. This has been fun.